Hello, I'm Corey Sandone. I'm the director of the Department of Art as Applied to Medicine, and I'm so pleased to welcome everyone to the class of 2025 Thesis and Capstone presentations for the graduate students in the Department of Art as Applied to Medicine. I also want to welcome and thank everyone in our YouTube audience who is watching live today. This is a major achievement for each of our 9 students, the culmination of their work on each of their master's degrees. Each student conducted original research and explored a solution to a biocommunication or a clinical challenge. For the first time, students in both our graduate programs are sharing the stage this afternoon for their presentations. First, David Reaney, director of our Medical and Biological Illustration grad program, will briefly describe the master's thesis projects for the Master of Arts degree, and then 7 students will present. Then Juan Garcia, director of our Clinical Anaplastology graduate program, will briefly describe the capstone projects required for their Master of Science in Clinical Anaplastology. 2 students will present, and then we hope guests will join us for the graduate exhibit opening reception following this. Each student will present and then take a few minutes immediately following their presentation for questions. We hope you'll ask questions or feel comfortable making comments. Thank you. David?
Good afternoon, everyone. What you're about to see is the culmination of 9 months of focused and intensive work by our incredible students. The master's thesis challenges each student to dive deeply into a scientific topic and explore illustration and communication challenges and media that, in many cases, are entirely new to them. As they develop their projects, our students take on many roles, including researcher, writer, producer, storyboard artist, illustrator, sculptor, programmer, and today, presenter. In their pursuit for clarity and creativity, they draw on the breadth of their training and talent to produce work that is captivating and didactic and executed with exceptional craftspersonship. But I invite you to look beyond the obvious visuals to see how each of these presentations represents a unique and thoughtful contribution to both the science it communicates and the ever-evolving field of biomedical illustration. Each student works with an advisor who is a faculty member from our graduate program, as well as with a thesis preceptor who is a clinician or researcher in another department of the School of Medicine. Preceptors propose research topics which students then choose from, and this collaboration results in a rich variety of subject matter reflected in the diverse and visually stunning presentations you'll see today. I do want to mention, because we are presenting to a general audience, that some of the thesis topics presented today deal with serious medical conditions, including complications of pregnancy. With that, it is my pleasure to introduce our first student presenter, Talia Mastalski. Talia graduated summa cum laude from the University of Pittsburgh in 2022 with a BA in anthropology. Talia?
Thank you, David. Good afternoon, everyone. My thesis work focused on creating visualizations for radiology students to better understand and recognize injuries to the craniocervical junction in medical imaging. Being a little slow. The craniocervical junction, or CCJ, marks a transition from the base of the skull to the cervical spine and is comprised of the occiput, the first 2 cervical vertebrae, 2 major synovial joints, and a complex network of ligaments. The density of these ligaments can be quite overwhelming to look at, but these structures have the incredibly vital task of enabling intricate head movement and stability while protecting vital neurological structures within the CCJ's limited space. When looking at medical imaging, this network of overlapping bony structures and thin, wispy ligaments is even harder to recognize and differentiate. When a patient comes into an ER with traumatic injuries to the neck, radiologists need to fully understand the anatomy of this region, as well as recognize what it should and shouldn't look like in scans to accurately and efficiently diagnose potentially fatal injuries. Diagnosis of CCJ injuries is often missed, as the small, torn ligaments can be difficult to locate, and the complexity of overlapping bones makes identifying avulsion fractures very challenging. Misdiagnosed or overlooked trauma to the CCJ can lead to significant morbidity and preventable fatalities. For many radiology residents, the CCJ is a notoriously stressful area of the body to learn due to the lack of solid resources outside the emergency room. A quick web search of a particular CCJ injury provides visualizations that are too generic and lack important soft tissue elements useful to diagnostic radiologists. A deeper dive into the subject will produce solid information in the form of research papers, but requiring busy radiology residents to read through long, text-heavy papers for every injury to the CCJ is not an ideal and reliable learning tactic. Therefore, we saw a need for CCJ visualizations that are clear, easily digestible, geared specifically for comprehending radiological imaging, and accessible to everyone. For the scope of this project, we chose to focus on 3 CCJ injuries. These were the C1 burst fracture with transverse ligament injuries, atlantoaxial rotary subluxation and fixation, and the atlanto-occipital dissociation, otherwise known as an internal decapitation. These injuries were chosen for their commonality, severity, and complexity. The objectives for this project: first, we created 3 animations and corresponding still images to visualize the injury mechanisms and anatomy of the CCJ to provide context for radiological imaging. Next, we conducted a study comparing the efficacy of animations and still images for learning and engagement. Finally, we evaluated and analyzed study results using statistical analysis. Scans of the skull and vertebrae were downloaded from NIH 3D and cleaned in ZBrush. Ligaments, joint capsules, and a spinal cord were modeled from scratch. Rough storyboards for each injury were sketched out, then staged with the 3D models. Animations were done using Cinema 4D, and materials and didactic colors were created with the Redshift renderer. Each render was then compiled, edited, and annotated in After Effects. 2D assets such as hematomas and injured characters were incorporated into the final animations to complete the storytelling of each piece. Finally, labeled comparisons of our model to actual MR and CT imaging were compiled into a series of slides that summarize the main points in each animation. To test the efficacy of our materials, a Qualtrics survey was sent to residents in diagnostic radiology and related specialties at 10 institutions, including the University of Maryland and Johns Hopkins. In our first 2 rounds of testing, we were able to recruit 31 participants. Due to several unfinished survey responses which had to be discarded, our randomized groups were unevenly distributed. The survey included a content-based pretest, our learning materials, an engagement and comparison survey, and a post-test. Participants were randomized into 2 groups, one receiving still images only and one receiving still images and a corresponding animation. To lessen the load required of the participants, we decided to only test one of our animations in this study. Our survey showed that our study materials were helpful for learning. There was a statistically significant improvement between pre- and post-test scores for both the still images only and the still images and animation groups combined. There was, however, no significant difference in learning between the groups, suggesting the addition of an animation neither helped nor harmed with learning. The same can be said about participants' engagement with the content. There was an insignificant difference between the groups, suggesting the addition of an animation neither helped nor harmed engagement. When our participants were asked whether they would prefer learning from the still images only or the still images and animation, our participants overwhelmingly chose still images and animation, as shown by the teal portions of the bar graph. Participants who completed the survey having watched the animation were more split on their media preference than those who viewed still images only. The same can be said with the participants' preferences for engagement. While our results from the previous engagement survey was insignificant, when asked to compare the two learning methods, the participants still overwhelmingly favored still images and animation for engagement in the material. Here we have a word cloud based on our participants' writing comments. Our participants provided thoughtful insights such as adding narration and sound effects to the animated materials. These ideas are worth exploring, but more user testing will be completed to determine if any of these suggestions is supported by a larger population of target users. Our survey had a small sample size, and we are recruiting more participants to our study. As of now, we are actively testing at 10 institutions. The result of this thesis project culminated into a series of deliverables visualizing 3 specific injuries to the CCJ. This included 3 animations, their corresponding slide decks, and additional assets for the final website, which included images with clickable hotspots and an interactive designed in Unity. These materials have been passed off to radiologists at the University of Maryland to eventually be used as resources in a free online learning module. The open source website will be a single-stop location for vital educational resources in trauma radiology. Our visualizations will allow learners to recognize the structures of the CCJ and the selected injury pathologies, as well as relate the 3D model to the associated imaging. The success of this project will provide insight into the value of 3D models and animation for enhancing radiological education, as well as provide a new resource to help residents better diagnose dangerous CCJ injuries that can often be missed. I want to thank my preceptors, Dr. Smith and Dr. Sinensky, and my faculty advisor, Jeff Day, for all their help and enthusiasm for this project. I'd also like to thank the Berzelius Trust and everyone who filled out our survey. Finally, I'd like to thank the faculty, staff, my fellow classmates, and my family for all their support and words of encouragement. Thank you, and I now welcome any questions or comments.
Hey Talia, so there's actually illustrations on this type of trauma, and the movements are really hard to see on imaging. Could you talk a little bit more about how you figured out how to animate and how to illustrate it?
Yeah, thank you, Jeff. The question was about how I came about animating everything with the resources I had, which were limited in illustrations and diagrams. And that really came down to working with my preceptors, Dr. Smith and Dr. Sinensky, who did some really deep dives into archives and found a lot of literature on the subject. And we kind of pieced together bits from here and there, and were able to piece together a lot of stuff about biomechanics and physics that I never thought I'd have to be doing in art school. So that was a really amazing experience to get to look that deep into the research that had been done. It was hard to find a lot of it, so that's why not all of our animations, we included a reference page at the end, so people who do want to learn more about it could also have an easier time finding more detailed information. Thank you.
Sorry, Nicholson. I was just curious if you talk about the approach technically to animating. Were you doing by frame, or were you trying to use physics? Because it looked really physics missing some of those.
Thank you. The question was how I went about the animation, if I used physics or anything involved. It was Cinema 4D, a lot of point level animation and pose morph tags. While in the animations, I don't specifically say any particular degrees of anything, we found some papers with particular angles of rotation. And so we incorporated that into the actual animation as best as we could to make it as convincing as possible. Thank you.
This is a pretty straightforward question about your color selection. Can you elaborate a little bit? Can you elaborate a little further on how you determine which colors?
Yeah. The question was about the colors I chose. I have 3 different animations, and they all had different color patterns. I tried to keep them simple. Each of them only had like 2 main colors and then a complementary color, basically. I chose the first one with like a blue color. It's very calming. And the next 2, I wanted to keep them a little bit different to be able to separate the 3. If you're like a visual learner, you can kind of think, oh, the blue one's this one, the green one's this one. But I tried to keep them so they all looked cohesive together in very similar style.
Can you also talk about the colors that you did?
Oh yeah, the colors for the didactic coloring, those were also chosen based off of looking at the WCAG, what works for color blindness and things. We tested a lot of different colors, had a lot of different examples going on, but we chose blue, purple for the ligaments and the capsules because they're kind of standard colors, and we chose the other ones for that compared nicely with those. Thank you. I think there was a question down here. There's a question down here, Elise, or down in the front.
To radiologists being able to use this, would any surgeons or doctors consider using it if a family member, let's say, had this sort of accident, and then using those illustrations that are really clear and be simple to understand, using it in an emergency room before you perform surgery on someone or on someone's family member?
Yeah, absolutely. The question was about if anyone else would be able to use the resources I made, such as surgeons helping their patients. And yes, that's how we kind of, why we tested also in our test group, some people who weren't diagnostic radiologists. We looked at like orthosurgeons and neurosurgery and anyone else who might be fairly interested in this. And we made, it's going to be accessible as like an open source resource, so other people could look at it as well. Thank you.
We have a question from our YouTube audience. It is, was the Unity tool distinct from the static images and the animation used in the study?
Yeah, thank you for the question. It was about what was the Unity tool, and I made a, the Unity was about normal anatomy, so that'll be used on the website as basically an introduction to the injuries. So it has all the ligaments of the craniocervical junction and bones. They're all clickable, rotatable, so you can kind of learn the anatomy. You can click on it and read a little bit about it before you dive into any of the specific injuries. Thank you. Now I'd like to introduce the next presenter, Alexandria Dannhardt. Alexandria received her BFA in pre-medical and scientific illustration with a minor in computer science from Virginia Commonwealth University. Alex graduated magna cum laude.
Hello, my name is Alex, and I'll be presenting my thesis that's about accessible education for Ludo patients. So my thesis focuses on improving patient education for lower urinary tract obstruction, or Ludo. It can also be referred to as bladder outlet obstruction, or BOO. Ludo is a fetal condition typically diagnosed around the 20-week anatomy scan, and it primarily affects the urinary system, but has secondary impacts on the lungs. The condition is caused by a blockage in the urethra, which leads to urine retention in the bladder. This causes the ureters to dilate and damages the kidneys. During the second trimester, the fetus is breathing an amniotic fluid, which is primarily composed of urine. That fluid is what pushes against the developing lungs and allows the alveoli to form. Without amniotic fluid, lung development is interrupted, and the internal pressure from the enlarged bladder and the lack of amniotic fluid can contribute to lung damage in a Ludo-affected fetus. Additionally, physical damage such as short limbs, joint contractures, clubbed feet, and facial malformations can occur because the fetus cannot move freely within the uterus. Receiving this diagnosis is overwhelmingly emotional for expectant parents. They're suddenly faced with complex, often time-sensitive decisions. In some cases, parents can monitor the condition, though this carries the risk of irreversible health issues. Parents may undergo interventions, but these interventions are risky for both the parent and fetus, and they cannot reverse existing lung or kidney damage. In severe cases, some families choose to discontinue the pregnancy, but this is an incredibly difficult decision, particularly in the second trimester after they've already shared the news of their pregnancy with loved ones. These conversations are made even more difficult by the lack of clear, supportive patient education materials. Most resources available online are dense, text-heavy web pages with vague descriptions and minimal visuals. Images are often unlabeled or uninformative and fail to convey crucial milestones in fetal development or the severity of the condition. Videos online tend to just be doctors talking to a camera. My goal was to create a new suite of patient-centered education materials designed not only to inform parents, but also support them as they navigate these conversations with their families. The tools that I made are intended to communicate the complex diagnosis to parents, help them share information with their support network, and empower them to advocate for themselves by coming prepared to medical appointments and asking the right questions. Once the materials were developed, my secondary goal was to test their effectiveness through a formal study. The core of my patient educational materials was a 4-minute animation. To make this animation, I sculpted and textured assets in ZBrush, retopologized them using ZWrap, and animated them in Cinema 4D. Within Cinema 4D, I manually animated using pose morphs or deformers controlled via espresso nodes. Let's see if that actually plays. There we go. Within Cinema 4D, I mainly animated using pose morphs and deformers controlled via espresso nodes and user data. I then rendered these in Redshift, composited them in After Effects, and did audio compositing in Audition. From there, I repurposed my assets to create other materials in Photoshop and Illustrator and used those to produce a printed handout in InDesign and built a WordPress website using Divi. With these materials completed, I conducted an IRB-approved evaluation, recruiting participants through the Parent Advisory Council and social media. Through Qualtrics, participants first took a pretest to assess their baseline knowledge. They were then randomly sorted into a control group, which saw the current Johns Hopkins handout, or an experimental group, which viewed my animation. Afterwards, they completed an engagement survey and a post-test, and then were given an opportunity to view the other resource and share comments. In the end, I created 4 key educational tools: the animation, the web page, the handout, and a 3D printed clinical model. Let's watch the first minute of the video, which is just the overview section and a little bit of the normal anatomy.
Overview. Lower urinary tract obstruction, or LUTO, sometimes called bladder outlet obstruction, or BOO, is a fetal condition that is diagnosed during pregnancy. This condition primarily affects the urinary system, but can also impact the growth of other organs, particularly the lungs, because these systems are closely linked during development. Normal development. In the womb, the fetus is cushioned by amniotic fluid, which allows its chest to expand. At 20 weeks, it begins to practice breathing movements, inhaling amniotic fluid instead of air. Similar to filling a water balloon, the inhaled fluid stretches the lungs, promoting airway development and helping to thin the tissue so gas exchange can occur. An important step in lung development.
So to accompany that video, I built an expanded website using WordPress and Divi. It presents the same topics in more in depth: healthy anatomy, anatomy of the condition, causes, diagnosis, developmental impact, and intervention options. The website is designed for flexible browsing. It's image-driven, skimmable, and sectioned for ease of use. The handout is also available on the website and is printable or available in the clinic, and it is a concise summary of the condition. It contains less information than the video or web page, but provides a quick summary of the condition and focuses on the topics most relevant to the clinical appointment. In addition, I made a 3D printed model to help show the difference of scale of organs. I first prototyped it in PLA to check mechanical fit, then printed it in clear resin. The advantage of the resin is it allows light to pass through the fetal bodies, illuminating the difference in bladder size with the pathological fetus. The internal organ blocks can be removed and compared directly, giving a tactile sense of scale and severity. The reviewers liked some of the models, though some people raised concerns about the emotional impact, so these have been revisited. With the patient education materials completed, let's look at the results of the survey. So I received about 160 responses, with 86 of them being usable for the knowledge test. The participants took a pre-test, then reviewed educational material and took a post-test on the same content. The video group improved by 6 points on the post-test, while the text group improved by 4. Both increases were statistically significant, but the video group had a significantly greater gain. When asked how confident they felt explaining the condition to someone else on a scale of 1 to 10, the video group again improved by about 5 points, while the text group improved by 3. Again, both were significant, with the video showing a significantly stronger effect. I also performed an engagement survey using Likert scale questions. On a scale of 1, strongly disagree, to 5, strongly agree, the video group outperformed the text group in all aspects. However, the change in scores between the two groups was not statistically significant. And finally, when asked directly which resource they preferred, 75% participants chose the video as their preferred method, while only 3 chose the text. So the animation handout and webpage will be available through my portfolio website, and the animation and handout will be shared with my preceptor, Dr. Cush, for use at the Johns Hopkins Fetal Therapy Center. The 3D model is still being refined. Like I said, some feedback raised concerns about the emotional impact, since holding a model of a fetus can feel inherently emotionally manipulative. So that is something I'm continuing to evaluate and iterate upon. I'd like to extend my deepest thanks to my preceptor, my faculty advisor, and the Thales Trust for their support, as well as the faculty, colleagues, and friends of the Johns Hopkins Department of Applied to Medicine. I will now take any questions or comments. No, I made the survey available to anyone over the age of 18 with the intention for this to be focused more towards the parents' peripherals, like their support system, so their friends and their family that might be wondering why the individual is having complications with their pregnancy. So I didn't restrict my my demographics at all, which really helped with survey responses. No, nothing about educational level. I posted it in a variety of places though, so I know I got a pretty wide variety of people. There is a statistical review subreddit that people volunteer responses at, and locations like that. So I'm assuming I got a pretty large range. Yeah, so David's asking about the use of ZRAP for making my pose morphs, I believe. Yeah, so ZRAP is a program produced by our R3DS, which is a company meant for retopologizing 3D scans. If you're familiar with ZBrush, it's kind of like the project tool on steroids. So you can make a unified or a uniform base mesh and use that to like place points of where that base mesh is going to meet your other mesh. So this allows me to sculpt really, really freely with all the different versions of the fetuses, and then tightly wrap the correct topology onto every model. And that way in Cinema 4D, when I use the pose morph, all of the point coordinates are at the same location, so they can smoothly mesh between one another without having to go through a lot of effort with keeping my topology the same when I wanted to be a bit more freeform and artsy at the beginning making my sculpts.
Hi, Alex. Thank you for your presentation. I was wondering about some of these survey questions you asked, specifically if you guys presented this one to people who are expecting children that maybe have this diagnosis of a child, if that's right, on that.
Yeah. So Naman was asking again about the demographics and about people that might be undergoing a diagnosis of Ludo and how they react to the video. Dr. Cush was wonderful enough to get me in contact with Johns Hopkins Fetal Therapy Center's Patient or Parent Advisory Council, which is a group of parents who are invested in the success of the Fetal Therapy Center, and they provide their feedback and their opinions on a variety of things. So we sent them a copy of the survey. So although the survey was anonymous, then I'm not sure who was from that group and who wasn't, a couple of people did leave comments that they had a child diagnosed with this, or that their child had passed from a similar condition, or that they felt empathetic towards people that had complications in their pregnancy. And overall, it seemed people were encouraged by the honesty of the information and having that at their fingertips, though people did have some responses that it made them feel sad or anxious, which I understand. One thing to note, and this may not be specific to the individuals responding from the Parent Advisory Council, is that people who watched the video gave more empathetic comments. There was more things about being sad for the baby, sad for the parents, while people who just looked at the text would say that's interesting. So although I feel a little bad for making people feel upset, I do feel that it supports my goal to make other people understand what the parent is going through and communicating the severity of the condition. Hey, Daisha.
I have a question for the two parts. She's asked, are the physical versus digital materials meant to supplement each other or cover the same material in different ways?
Hi, thank you for the question, Faith. So the question was whether the digital materials and the physical materials are meant to complement each other. Ideally, most of the digital materials, most of the physical materials are available digitally. The handout is available digitally, and the web page actually has a PDF version on there, so you could print out the web page directly. The only thing that doesn't really complement is the 3D models that are meant for use in the clinical rooms, but those are still being evaluated anyway. So hopefully there is no disconnect between what the patient can experience in the room and outside of the room. And one of the benefits of the handout is they can take that home, and it has links to the web page and the video, so parents can either remind themselves about what was discussed during the appointment or share it with other people. So everyone should have equal access to that information. All right. Well, thank you guys so much for your attention. I would like to introduce, thank you. I would like to introduce my classmate, Kavita Subramanian. She earned her Bachelor of Design degree from the National Institute of Fashion Technology in India.
Good afternoon, everyone. Thank you, Alex. My name is Kavita Subramanian, and my presentation is going to be on mitochondrial biogenesis and the progression of Parkinson's disease. So to begin with, Parkinson's disease is the second most prevalent age-related neurodegenerative disease, with worldwide cases estimated to increase to 9 million affected individuals over the age of 50 years by the year 2030. Parkinson's disease is caused by the dying of dopaminergic neurons in the substantia nigra in the brain stem. The brain makes up 2% of the body weight but uses up 20% of the energy, so the neurons require a consistent supply of energy. And indeed, a common characteristic in Parkinson's is dysfunction of energy production in neurons. Energy in neurons, as in most cells, is produced within organelles called mitochondria. They have a folded inner membrane, or cristae, seen here, surrounded by an outer membrane. While this is the structure of mitochondria we are familiar with, recent scanning electron microscopic photography shows mitochondria as more elongated branched organelles as these light blue structures here. They dynamically undergo fusion to become larger organelles or undergo fission to become smaller organelles that can then be transported to different locations in the neuron as per energy requirements. They have specific branching structures depending upon the type of neuron, and I have incorporated this more accurate elongated branch structure in my thesis. The mass of mitochondria in neurons can increase or decrease, and this balance is maintained by two constantly occurring processes of mitophagy, the selective clearing out of damaged mitochondria, and mitochondrial biogenesis, the creation of new mitochondria from existing ones. While dysfunction in mitophagy was considered to be a key factor in Parkinson's disease progression, it has been recently discovered that neurons have built-in redundancies to continue mitophagy. Instead, growing evidence points to dysfunction in mitochondrial biogenesis as being key in Parkinson's disease progression and hence promising for therapeutic intervention. Mitochondrial dysfunction is played out in the interaction of three molecules, PINK1, Parkin, Paris, and the resultant repression in Parkinson's disease of master regulator molecule PGC1 alpha. Experimental models show that agents targeting Parkin and Paris to your left improve mitochondrial biogenesis in the neuron and protect against neurodegeneration. Current material for education about this pathway includes content and visuals that are complex with limited viewer engagement, narrowing the audience to experts in the science of Parkinson's disease. Also, static 2D images are less effective in expressing the progression of interactions across space and time. This is a graphical abstract I prepared for this pathway with normal and mutant molecules at every stage of interaction with Paris, and it's still quite complex to communicate with a wider audience. Instead, this thesis aims to educate a general audience about this pathway using an engaging 3D animation that's about 3.5 minutes long. And this will serve as an introduction to explain the interaction of the molecules more effectively with their changes across space and time. And further, an interactive web module will allow for repeated engagement with the more detailed material for self-directed learning for clinicians, scientists, and students. To begin with, the relative sizes of the molecules were first established from research and the molecular structures obtained from the RCSB protein data bank. And since the structure of Paris was not fully realized, predictive AlphaFold AI was used to obtain an approximation. The structures were then brought into Maxon's Cinema 4D for 3D modeling using the EPMV plugin. Then the scenes were eventually rendered using Maxon's Redshift. The structure for the cerebrum was obtained from Pixel Lab, and the brainstem and cerebellum were modeled in C4D. The 2D interactive web module was created in Unity and uploaded to play in the browser in the WebGL format. The storyboard was created and timeframes for the scenes were planned from a scratch read of the script in Adobe Audition and roughly animated as shown here into an animatic in Adobe After Effects to plan animations of the molecules, special effects, pacing, duration of clips and transitions, and post-production was completed in Adobe After Effects, Photoshop, and Illustrator. Play models of the assets were then created in Cinema 4D as concept art, then 3D render was completed in C4D with lighting materials, didactic colors added to distinguish the molecules. Efforts were made to strike a balance between stylistic representations of the molecules and processes while maintaining scientific accuracy. These are the results. Here is a short clip of the animation.
Neurons consume a large amount of energy during normal activity. They are powered by mitochondria. Mitochondrial efficiency relies on a delicate balance between regular mitophagy to clear out defective mitochondria and mitochondrial biogenesis to replenish or increase their numbers. In Parkinson's disease, this balance is disrupted when damaged mitochondria are no longer cleared out by mitophagy and new mitochondria are not created through mitochondrial biogenesis. This leads to insufficient power and the inevitable death of neurons. Key in this disruption is a pathogenic molecule found in the cytosol called Paris, or Parkin interacting substrate. It directly disrupts the power supply of the neuron by affecting the generation of new mitochondria in mitochondrial biogenesis. When Paris nears a mitochondrion, it is phosphorylated by an outer mitochondrial membrane protein called PINK1, allowing another molecule in the cytosol called Parkin to recognize it and mark it with ubiquitin, signaling its degradation.
Next, I have a short segment of the interaction in the web module. The interactive allows the user to choose one of 4 pathways by choosing molecules at each stage. Once the choice is made, the viewer sees a short video clip of the effect the choice had. The text on the left has notes on the signs and a short instruction for next steps. Depending upon the choices made, Paris in the end either clears or does not clear from the neuron, which causes the neuron to either continue or to die. This exploratory interaction allows the onboarding scientist or student to understand the nuances of the pathway. It could also form the basis to illustrate interventional strategies in the future. Finally, a cheat sheet shows the summary of the interactions between the molecules. And the game can be reset, allowing the user repeated engagement with the materials. Future developments for this project include assets for Paris can be easily updated when the molecular structure is completed. And secondly, the assets can also be updated as research progresses and adapted for education about new therapies in the future. I would like to thank my wonderful preceptors, Drs. Ted and Valina Dawson, and my amazing faculty advisor, David Reaney. I would also like to thank members of the Dawson's Lab, the amazing faculty at Art is Applied to Medicine, my talented cohort in the class of 2025, as well as the class of 2026 for their assistance with today's presentation. Thank you kindly. I can now take questions or comments.
Tell us a little bit about how you find it for your animation
The question is, if Paris has not yet, the molecular structure of Paris has not yet been fully realized, how did I go about designing it? Thank you for the question. So Paris, most of the structure was complete, but there are several options that artificial intelligence was used in the form of AlphaFold to predict the structure of Paris. And so I worked with a lab basically to get the best approximation of the ones available to use in the animation.
Question is Steve to elucidate the complexity of biogenesis and what that very deep story. You talk a little bit about how you design that. Our story are established that.
The question is, how did I distinguish mitophagy and mitochondrial biogenesis for the purposes of storytelling? Thank you for the question, David. The interesting part of this project for me was trying to get several nonlinear aspects of the storyline into a linear narrative. And mitophagy and mitochondrial biogenesis are critical to this concept. Along the way, I learned a few interesting things, like, for example, the way fission occurs so fission, the breaking up of mitochondria, occurs for both mitophagy as well as mitochondrial biogenesis. But in case of mitophagy, it is just one small corner of the damaged mitochondria that buds off, whereas for mitochondrial biogenesis, the fission happens more centrally and a larger portion of it buds off. So it was interesting putting these details into the animation. And it was important for me to get a clear visual distinction between the mitochondria that was damaged and the mitochondria that was getting ready for biogenesis. Does that answer your question? Well, thank you very much. I would next like to introduce my classmate, Hannah Forward. Hannah earned her BFA in illustration with a concentration in sequential art from the Maryland Institute College of Art. Hannah completed her science coursework at the University of Colorado, Boulder.
Hello, my name is Hannah Forward, and today I will be presenting my thesis on creating accessible, patient-centered education materials for fetal blood sampling and intrauterine transfusion. I worked on this along with my preceptor, Dr. Miller, and my advisor, Dr. Jeff Day. When a fetus is found to have an unusually low red blood cell and hemoglobin count, they are diagnosed with fetal anemia. Fetal anemia is a condition which, left untreated, can cause significant harm to the developing fetus by damaging the brain and overtaxing the heart, eventually resulting in fetal loss. Fetal anemia cases are increasing in the US due to infection trends. Intrauterine transfusion, or IUT, is the most common treatment for fetal anemia. Under ultrasound, a long needle is carefully inserted into the umbilical vein. Through this needle, blood can be transfused into the fetal circulation or drawn for testing. When performed by an experienced team, IUTs are successful 97% of the time. Currently, though, there are no published best practices for IUT, meaning the procedure can vary from center to center. Additionally, most centers in the US perform fewer than 10 IUTs per year. Given the dangers of an incorrectly performed IUT, it is vital that patients are familiar enough with the procedure to self-advocate. This is easier said than done, however, as patients often have fewer than 72 hours between referral and treatment, leaving very little time to research. Existing patient resources for IUT swing between overly brief and too dense for the average patient to parse, and may contain outdated or sometimes even incorrect information. To address the lack of patient resources for IUT, as well as the short time frame, we decided to create a brief online animation for patients to view before their appointments that depicts how a high-volume specialty center typically performs IUT. This decision was informed by evidence-based learning principles, such as the cognitive theory of multimedia learning and the dual coding theory. With all this in mind, our objectives for this thesis were: create an animation that will educate patients of different health literacy levels about IUT and what to expect during and after the procedure. Iteratively develop content with user-centered design to produce materials that best suit our audience's needs and interests. Assess the animation's educational value and patients' emotional response to the material. Before production began, I conducted interviews with experts from the Johns Hopkins Center for Fetal Therapy and patient stakeholders from the Allo Hope Foundation. The foundation supports allo-immunized patients who have incompatible blood types with their babies, many of whom have been treated with IUTs. These interviews informed the accuracy, content, and empathetic approach of the animation. Experts and stakeholders were again consulted at key creative checkpoints throughout the production phase. I was also given the opportunity to observe an IUT being performed at the Center for Fetal Therapy. We then moved on to production. Storyboards were reviewed by doctors and Allo Hope patient stakeholders. Animation assets were created in Photoshop and Illustrator. And finally, the animation itself was created using After Effects. We conducted a survey to evaluate the effectiveness of the animation as a patient education material. To measure the animation's understandability, we had participants score the animation using the Patient Education Material Assessment Tool for Audiovisual Materials, a validated testing tool developed by the Agency for Healthcare Research and Quality. We also had participants rate the animation and answer several open response questions to measure emotional responses to the animation. Participants were recruited from among Allo Hope's Patient Advisory Council and from acquaintances who had been pregnant in the last 5 years. The survey was conducted anonymously using Qualtrics. Now I'll show a segment of the final animation.
Preparing for the IUT. The goal of an IUT is to first take a blood sample, then give the baby new blood. During an IUT, the patient is usually awake, lying down, and kept warm and comfortable with blankets. Local anesthesia helps numb the skin and the area all the way down to the uterus. Additional pain medication can be given at any time to help with discomfort. Before the procedure starts, an ultrasound checks the baby's position and informs where the needle should be placed. Most often, the doctor targets the umbilical vein, which brings blood and nutrients from the placenta to the baby. The needle can enter the umbilical vein in the part attached to the placenta, the part in the umbilical cord, or the part in the baby's liver. If none of these areas work, or if the vein is too small, the doctor can also give blood directly into the baby's abdomen, where it is absorbed into the baby's circulation. The location of the needle placement depends on how the baby is positioned and where the placenta is attached to the uterine wall.
On to the results of the survey. The average PMAT AV score was 10.7 out of 11 total points, or 97.5%. A minimum score of 70% is needed for material to be considered understandable. In the open response portion, participants mentioned seeing the different needle insertion locations was the most educational part of the video. Participants rated the video 4.4 out of 5 stars and said they were likely or very likely to recommend the video to someone about to undergo IUT. In another open response question, 70% of the emotions participants said they associated with the video were positive, with the most common positive feelings being common confidence and the most common negative feeling being anxiety. To recap, we created a 5-minute patient education animation that gives an overview of how an IUT procedure is typically performed at a high-volume specialty center. The content was developed in collaboration with content experts and patient stakeholders. Our testing showed that our animation was effective, understandable, and calming. Final suggestions included providing more information on topics like potential complications and physical sensations the patient may feel, as well as adjusting the voiceover to sound a little friendlier. Next steps for this project include refining the material based on the feedback we received in our survey, posting the video on the Hopkins Medicine YouTube channel for broad discoverability, and creating a web page on the Hopkins Center for Fetal Therapy website where patients can access the video. A huge thank you to my preceptor, advisor, patient stakeholders, and the Vesalius Trust for supporting this project, as well as the faculty and staff of Art as Applied to Medicine and my beloved class of 2025. Thank you for your attention. I will now take any questions or comments.
The curriculum of self-efficacy, patients advocates first, and then I can really involve for procedures patients to provide patients with content. Just curious in regular projects, specific
Yeah, so the question was, how did I try to address the need for self-advocacy throughout my project and in different aspects of my project? So when I consulted my patient stakeholders from Allo Hope throughout this project, they gave me tips on language and certain topics that should be included in this video based on their own past experiences with IUT and with helping IUT patients advocate for themselves. The crux of the issue is usually just that patients about to undergo IUT don't have even a baseline of knowledge to go off of to know if something is, being performed incorrectly or not being performed at all. For example, some patients reported never having received a fetal paralytic, which is a lot less safe than, receiving one, obviously, when you're sticking a needle near a fetus. So, details like that, I think my patient stakeholders really helped me hone in on to help viewers at least have that baseline of knowledge from which they can advocate from.
And thank you again for your presentation. Great. You had mentioned towards the beginning that there's usually less than 72 hours between the referral and treatment. Could you assess and talk a little bit about why that time frame is so short? Is it just a season? Was it that like patients to be more informed into the very urgent structure of this? Which is you guys thought of to have the desperation stress.
Yeah, so the question was, one, why is there such a short window of time between at least a presumptive diagnosis and a referral? And two, what are some ways that we tried to combat the stress that a patient might be feeling during that time with this video? So one, there is such a short window of time because it's considered an urgent situation. If fetal anemia is suspected, depending on the severity of that fetal anemia, the fetus could be at risk of, serious permanent damage. So it's important for that appointment to happen very close to the diagnosis. And two, we tried to keep this video calming in nature, obviously. So the way I went about that was I portrayed the patient in my video as being very calm and the team of doctors also being calm and even, happy, which did reflect what I saw when I observed an IUT. It is, important that nobody in that room is super stressed out. And another detail I made sure to include was I never show a needle directly entering the patient. It's a pretty large needle, and I think it's the source of a lot of fear for patients about to undergo this procedure. So I wanted to handle that as delicately as I could. Yeah, no. So the people that did elaborate, not everybody elaborated on the emotions they were feeling, but the people that did elaborate mentioned that they were anxious or fearful just because of the situation that our patient is in here, especially for these people who have likely had IUTs themselves before. I think that there is a lot of anxiety associated with the procedure, no matter what you do. So I was just thankful that we got it down to 30%. Honestly, I feel that that's a pretty good achievement.
So let's say long procedures. Because I think for somebody, I would be asking like, oh, so how long position?
Yeah, so I received some records from IUT procedures performed in the past year at Johns Hopkins, and there were some that were quite short due to probably an aborted procedure, and some that were quite long, like an hour or so, due to the combination of this procedure plus another procedure such as like a twin-to-twin transfusion, but the average time was about 20 to 30 minutes. No, that is good information though, and perhaps something that can be included in a future version of the video.
T Mama has a question. So if the material is supporting patient self-advocacy, would this be provided by a physician, or is it something that the patient might find on their own?
So my goal for this, although this is the procedure I depict does have a couple details that are specific to the way that the procedure is performed here at Johns Hopkins Hospital, along with other rarer high volume specialty centers. I wanted the experience to at least, some aspects should be universal. So ideally, if someone is referred to Johns Hopkins Hospital, this is a video that would be given to them when they make their appointment to watch before they come in or even in the waiting room. And then if someone is outside Johns Hopkins Hospital but has been referred somewhere else or is even receiving it from their MFM, I would like them to be able to search, IUT, what happens during an IUT, and find this video to at least have some sort of baseline for what will happen. I forgot to repeat the question.
My question is, even though the condition does have the word fetal, do you intentional using language that would not bring in the whole controversial modeling of with women and using fetus instead of baby?
So the question was I, did I make a decision between using the word fetus versus using the word baby? So in clinical context, fetus is correct, but because this was geared more towards patients, I did make the decision to use the term baby throughout my video because I felt that it was a little warmer and I think more what patients are looking to hear versus fetus, political context aside. All right. Thank you, everybody. I would now like to introduce my classmate, Terry Nguyen. Terry earned 3 undergraduate degrees from Rowan University, a BFA in Biomedical Arts and Visualization, a BA in Studio Art, and a BA in Music.
Hi, everyone. Thank you so much for being here. A lot of meaningful work has been done for medicine through my cohort's theses, but we're going to take a step back. We're going to go to the Caribbean and we're going to talk about rodents. And my thesis is Hispaniola's Lost Rodents and Niches, integrating 3D, 2D reconstructions with data visualization, isotopes, and anatomical analyses. And I guess I should mention that my name is Terry Nguyen. We are currently facing a biodiversity crisis with alarming increased extinction rates that's primarily driven by human impact, such as direct persecution and deforestation, as well as climate change. Hispaniola is the second largest island in the Great Antilles of the Caribbean, and it once hosted the greatest rodent family diversity. Now, only one endemic rodent survives, the Hispaniolan hutia, also known as Plagiodontidium, that is seen on the left, alongside the invasive common rat, Rattus norvegicus, that was introduced during European settlement, which was around the 1490s. So to geographically orient ourselves, we are in the Caribbean region with Florida in the upper left corner. Hispaniola is next to Cuba and Puerto Rico. It is also politically divided by Haiti and the Dominican Republic. So why should we examine this extinction phenomenon? Hispaniola's highly endemic, specialized fauna make it a valuable model for understanding local and global extinction patterns because of how insular it is. We can use this knowledge to make better informed conservation strategies. In my thesis, I specifically examined the zygomastocytic system and isotopic data from fossils and teeth enamel of select extinct rodents from Hispaniola to better understand their mastication or their chewing, dietary habits, and ecological niches. The zygomastocytic system is the anatomical and functional relationship between the zygomatic arch as well as the masseter muscles. In rodents, this system is so specialized that it can be compared to the specialization of bipedalism in humans. Virtually no ecological work has been done on these extinct rodents. There are currently few to no illustrations and artistic reconstructions in academic and popular literature. This is a taxonomy of the rodents I studied. It can be a bit confusing, but the main takeaway is a division between hystricomorphs and myomorphs, which you can see under suborder. For hystricomorphs, you can think of your common guinea pig and capybaras, and myomorphs are your mice and rats. These animals could inform me about how these extinct rodents might have looked. And these are the 5 species that I did a comparative analysis on. The extinct species are in orange, and the living ones are in blue. There are 4 objectives to my thesis. The first is the 3-dimensional reconstruction of 3 extinct rodent species. And from those reconstructions, I developed 2D tonal anatomical illustrations of the zygomastocytic system in orthogonal views. The third objective was to comparatively analyze the zygomastocytic system between the 3 extinct species and the extant or living P. adium and R. novechicus. Finally, the last objective is to visualize the isotopic data between all the species. The primary audience is researchers like paleontologists, conservation biologists, and educators, specifically concentrating on Caribbean ecosystems. The first step for 3D reconstruction is data acquisition from the Smithsonian, Florida Museum, and Museo de Historia Natural. From the segmentations, a series of alignment, extraction, mirroring and averaging, move manipulations, and cross-references were done to complete the 3D reconstructions, and these were all done in ZBrush. For example, we can look at the before and after of the extinct species reconstructions. This is the initial phase in ZBrush, where I examine what segmentations I am working with. From the separate segmentations, I was able to restore certain missing anatomical structures and align the skull, mandible, and dentition as seen fit. For the extant species, or the living species, the reconstructions were derived from surface scans as opposed to micro CT scans and were more well preserved. Derived from the 3D reconstructions are the anatomical illustrations. These were all tonal and completed in Photoshop. There are 3 layers of masseter muscles, including the superficial, intermediate, and deep layers. I also included line drawings of the mandible and cranium for better visualization of the dentition. Here is an example of all the assets I did for one of the species, Hexalobodon phoenax. This was done for all 5 species. From these visualizations, I wrote clarifications of the observed anatomical differences, as well as all the relevant bony landmarks, which were labeled, and the muscles. And this is the overall breadth of the illustrations that I did. These observations went beyond the content of my preceptor's papers and are my original comparative anatomical analyses. For the data visualization component, I reviewed my preceptor's primary paper on isotopic data and depicted a bar graph. And from this bar graph, I created a graphical abstract that showed the isotopic data of the species in relation to the rodents' respective diets and general habitat. Stable isotopes preserved in tooth enamel fossils can shed light about an animal's diet or ecological niche. When animals consume other plants or even animals, chemical signatures from their food, like specific ratios of carbon and oxygen, are imprinted into the dentition. Stable isotopes are like chemical fingerprints that capture what types of food the animal ate and where it foraged. Carbon isotopes, which you can see along the y-axis, can be correlated to the elevation or height of foraging. Oxygen isotopes, which can be seen along the x-axis, can help distinguish between the types of plants consumed. Any overlap suggested potential competition in food sources. For example, significant isotopic overlap between B. veratus and invasive R. novechicus suggests competition in food sources. You could even infer that the rat outcompeted B. veratus and was one of the contributing factors of the species' extinction. In summary, I completed 5 total 3-dimensional reconstructions, 50 anatomical illustrations, which meant 10 per species, 1 bar graph, and a graphical abstract. Overall, isotopic niches of these species illustrate specific ecological preferences. The combination of muscle morphology and stable isotopes offers an opportunity for comparative analyses. I would also like to point out that my inferences are solely based on a specific cranial region. Postcranial morphology would be worth investigating. My illustrations were also scaled for visibility and are not proportional to each other. Data on body mass is also an important factor to consider. Future directions include developing 3D prints of the skulls for better visualization of their mastication. I will also be reconstructing 1 more extinct species to refine and create a more holistic comparative analysis, and I will be using that to work towards a journal article publication. I would like to take this time to thank my preceptor, Dr. Cook, and Lazaro Vino Lopez for his constant anatomical feedback. I would also like to extend my thanks to Kate Hensley for the thorough explanation of stable isotopes. And last but not least, I'd like to thank my preceptor, Tim Phelps, for his constant guidance. Thank you very much, and I'll take any questions or comments.
That's really cool. I was wondering if the isotopes were evenly distributed throughout the whole skeleton, or once you look at concentrated in the teeth.
The question was, are the isotopes derived from the tooth, or if it's representative of the entire skull? Is that the question you were asking? Okay, specifically from my preceptor's, Dr. Cook's paper, I understood it as being specifically derived from the teeth enamel. There are more data on, for example, nitrogen isotopes, which I don't cover, and that would be with connective tissue and at a different region for the body.
Beautiful illustrations. I'm wondering, the reconstruction of brain and that seems pretty straightforward from the sources of muscle and wondering what type of research they were doing to inform distance and the shapes of the muscles and surgeons. Also, if you notice any changes, including different groups,
Sure. The question was, how did I make my informed decisions with reconstruction, since the segmentations were quite clean when I received them? And I will answer that one first. That I had to hunt down the fossils from Smithsonian, and Dr. Cook had a lot of good clean segmentations. In terms of references, there were maybe 2 references that I treated like holy scriptures because not a lot of people do research on that. So I used those. I had an atlas on guinea pigs, and I used that to sort of infer where the masseter muscles were. But about a week in, I realized they were quite different from each other. So I used specifically sort of ridges in the mandible to inform, oh, this is probably where the muscles were attaching. And so those were kind of the primary reasons why I made the decisions that I chose to. And I always went back to Dr. Cook to make sure that it made sense and it matched with the literature. I am so sorry. Would you mind repeating the second part of your question one more time? You're good. Sure. The question was, were there differences anatomically that informed the dietary almost niches or what they ate? And from my reconstructions, I did notice that certain species had more enlarged superficial muscles or superficial masseter muscles, and that suggests that they were able to do a lot of anterolateral motions, and that just means, I'm gonna do a demonstration. That just means that they move their jaw forwards and backwards a lot, so they're gnawing, they're chewing on a lot of different types of plant materials. And specifically in the living species, Plagiodontia idiom, the cute one you saw earlier, and the rat, those 2 had a much wider isotopic range as well, and their masseter muscles were quite unique in their own way. And those informed me that they had a general diet versus more specialized diet that we kind of saw in the extinct species. So this just means when you're so in your niche, when some new changes come that's foreign to the island, you're not going to be able to adjust to it, and you unfortunately may not be able to survive as a result. So someone or something like Plagiodontia or the rat that has more of a general diet has better chances of living, and it gets kind of reflected in their masseter muscles, specifically the superficial masseter muscles.
Very novel project presentation. I was wondering how you guys went through recreating a lot of these species with the notion of using a lot of these illustrations. I would say that what they present will create a better understanding of conserving species that are usually threatened to extinction, or changes in how we can access.
That's a great question. The question was, despite all this nitty-gritty work, the specific analyzation of the zygomasseteric system, when we take a step back, what is the bigger picture in terms of conservation? And sometimes when we're so neck deep in our theses, we forget the bigger picture or almost the point of research. In terms of my particular thesis, regardless of where you stand in terms of conservation or politically, it's important that we dedicate time, energy, and budget in terms of conserving the different types of ecosystems that are around globally. In Hispaniola specifically, there has been some historical turmoil politically between Haiti and the Dominican Republic. And so sometimes when people search about those places, they're more focused on the history and the political strife. And sometimes it's important that, maybe at this time, we're not focusing on the budgeting for those things, but it's better that we pay attention and we preserve those educational materials and the accessibility of them and preserve them before we lose them for good, because they're not going to come back really easily. It's going to take a lot of effort and time. I hope I answered that question. All right, I think that's all the questions I can take. Thank you. I would like to take this time to introduce my next student colleague, Carolyn Chen. Carolyn Chen graduated with a BA in chemistry and an additional BA in Asian studies from University of North Carolina, Chapel Hill.
Hi, everyone. Oh, is that too loud? Okay. Hi, everyone. So as Terry mentioned, I'm Carolyn, and I am so excited to present to you today my thesis, an interactive educational module for MRI evaluation of placenta accreta spectrum. So first of all, what exactly is placenta accreta spectrum, or PAS? It is a spectrum of disorders where the placenta is adherent to or invades the uterine lining of the uterus. This prevents the placenta from detaching normally during delivery. PAS is categorized by depth of invasion. A normal placenta will be separated from the myometrium of the uterus, or the muscular layer, by the decidua. In placenta accreta and increta, the decidua has been disrupted, and the placenta adheres to or slightly invades the myometrium. The most severe form of this disease is placenta percreta, where the placenta has been disrupted, where the placenta has disrupted the uterine serosa and can even invade surrounding organs, such as the bladder. So why does this matter? There is increased maternal and fetal morbidity and mortality for patients with PAS. This is primarily due to the high risk of hemorrhage, as the placenta contains a high volume of maternal blood. Moreover, the incidence of PAS is increasing as more people opt for cesarean deliveries, which are a major risk factor for PAS in future pregnancies. So how do we treat PAS? Many patients will undergo a cesarean hysterectomy, where the fetus is delivered surgically via cesarean section and the uterus is immediately removed following. Patient outcomes are greatly improved when multidisciplinary care teams are involved. Radiology plays a significant role on these care teams, especially in diagnosing PAS. While the primary modality is ultrasound, typically performed in the second trimester, MRI is a helpful adjunct for diagnosis and is especially helpful for operative planning. However, the appearance of PAS on MRI is complex and can be very difficult to read. There is also an overall lack of educational resources for understanding the complexities of placental MRI. The current standard is review articles and society guidelines, which look a little like this. So with all of this in mind, I went into this project with three main objectives. The first, to determine radiologists' preferences for educational media. The second, to design and develop an interactive learning module that illustrates the principal features of PAS on MRI. And lastly, to assess the efficacy of the module in a randomized controlled trial, particularly looking at knowledge gain and learner engagement. So to better understand how radiologists prefer to learn, I conducted a needs assessment with 5 attending radiologists at Johns Hopkins. These took the form of semi-structured interviews with questions aiming to assess their confidence in identifying PAS on MRI, identify their preferences in educational media when learning about placental MRI, and explore perceived problem areas for identifying PAS on MRI. After that, I used Figma and FigJam to ideate and draw up some wireframes for the interactive. I finalized illustrations and assets in Adobe Photoshop and Illustrator, and the final interactive was developed in Unity. After the interactive was completed, I conducted a randomized controlled trial, which was distributed as a Qualtrics survey to 106 radiology faculty, fellows, and residents at Johns Hopkins. All participants completed an introduction and pretest before being sorted into a control or experimental group. The control group read a review article about placental MRI, whereas the experimental group used the module. Both groups would then complete a post-test, which was identical to the pretest, before being presented with the media for the group that they were not sorted into originally. Participants would then complete a final engagement survey about their preference. We received 25 complete responses, yielding a response rate of about 24%. Now onto the results. The needs assessment revealed that radiologists feel that interpretation of placental MRI is extremely challenging, citing lack of experience and limited educational resources as major factors as to why. When asked to evaluate their confidence evaluating PAS on MRI on a scale of 1 to 10, with 10 being very confident, the radiologists rated their confidence at an average of 3.2, with a range of 1 to 5. As far as things that would be helpful for learning to interpret PAS on MRI, radiologists said that simple illustrations clarifying complex imaging features, as well as dynamic, scrollable case studies would be helpful. In response to this, I created several diagrammatic illustrations to clarify 7 primary imaging features of PAS. The sagittal and axial plane were identified as the most helpful when reading MRI for PAS, so I created these 2 illustrations of a pregnant person and used them as a base to build upon the other features. In these base illustrations, the fictional patient has placenta previa, which is where the placenta covers the cervix, but the appearance of the placenta is otherwise normal. I also developed case-specific illustrations and incorporated them into the module with opacity sliders to help clarify the relevant features. And these are annotated as well. I also incorporated some scrollable case studies into the module, which have labels as well. As for the results of the randomized controlled trial, both groups scored about the same on the pretest, and both groups experienced an increase in post-test scores. However, there was not a significant increase in scores for the control or article group, whereas there was a significant increase in scores in the experimental or module group. On the engagement survey, all participants expressed a preference for the module over the article. Common themes from the open-ended responses were that the module was organized, with clearly defined abnormalities and better images. Participants also responded positively to the visualizations in the module, which included the diagrammatic and case-based illustrations, as well as scrollable case studies. All 3 received an average 5 out of 5 on Likert skill rankings for helpfulness, with 5 being very helpful. So the interactive module was effective at increasing both knowledge gain and learner engagement. The implementation of suggestions and visualization preferences by the end users, in this case radiologists, during the research period of this project was crucial to the success of the design. The results of this study can also provide some valuable insight into the future development of educational media of complex clinical conditions for radiologists. Such interactive aspects of this project that were noted for being particularly helpful were the opacity sliders and the annotated scrollable case studies. Future directions include continued development on the module now that we have user feedback from the study, as well as increasing the study sample size. An additional study site is underway through the Society of Abdominal Radiology. We also plan to distribute the final module through teamrads.com, which is a learning website hosted by Johns Hopkins Radiology. I'd like to give a shout out to my awesome thesis preceptor, Dr. Erin Gomez, as well as my amazing thesis advisor, Lydia Gregg. I'd also like to shout out the staff, faculty, and my classmates at the Hopkins Department of Art as Applied to Medicine and the Vesalius Trust for providing funding for this project. Thank you for your attention. I can take questions and comments now.
It's fantastic research on so much data upfront within the system. Just curious, just to sort of summarize all of the study, just maybe where the contract create similar or box similar module or how is the what would be assigned to this?
Yeah, well, thank you for the comments, Lydia. I really appreciate it. So the question was, if I were to repeat a project with a similar clinical condition, so MRI or CT, what are sort of the main points that I would want to hit on in, going about this project? And I think definitely the most significant thing for myself in creating a successful design for this project was the primary needs assessment and interviewing attending radiologists and asking, aside, in addition to content that you would find helpful for this project, how would you want that content communicated to you? And I think, them really emphasizing simple diagrammatic illustrations that clarify, clear up some of the complexities or maybe some of the noise and artifacting that's common in these images would be the most helpful thing so that I can see the borders of the anatomy. I use the word borders in this case specifically just because a big thing about reading placental MRI is, where is the uterus, where is the placenta? So I think those were the biggest things, and I would kind of want to identify similar pain points in whatever clinical conditions that I could also be asked to create a similar project for.
Carolyn, in your presentation, I was wondering if the modules and education groups we created primarily for radiologists, people that didn't have the application for patient education, essentially allow patients to understand the different marks and the uses and developments. Move it that.
Yeah, thank you for the question. The question was, would this interactive have any application in being used for patient education? So my answer to that is the primary audience for this project was indeed radiologists. However, there was a secondary focus on general practitioners who might be ordering imaging. As it currently stands, there are very few experts in placental MRI in the country. So a lot of time, patients will be referred to these centers with a specialist who can read these images. And this module is kind of intended to increase accessibility to radiologists who maybe don't specialize in placental MRI, but also for, again, those general practitioners who might be ordering imaging outside of an ultrasound as well. So with that being said, patients were not my primary focus for this project specifically, but I could definitely see some application in, patients understanding the benefits of different modalities of imaging for understanding this condition. And I think that's all the questions that I can take. So I would love to introduce my classmate, Abigail Rumpp. She graduated from McKendree University and received a BA in biology with a minor in art, as well as a BS in biopsychology.
Hello, can everyone hear me? Okay. Hello, my name is Abigail Rumpp, and today I'd like to share with you the work I did for my thesis project on patient education materials for ovarian cancer and salpingectomy. I worked alongside my wonderful preceptor, Dr. Rebecca Stone, and my fantastic advisor, Corey Sandone. Ovarian cancer is one of the deadliest gynecologic cancers. It affects about 1 in 80 women, and less than half of those will survive 5 years after their initial diagnosis. The term itself, ovarian cancer, is a bit of a misnomer, as 90% of ovarian cancers start in the fallopian tubes, not the ovaries. Ovarian cancer is often called an invisible disease, as there are no screening methods, and symptoms like bloating, pelvic pain, or fatigue are vague and easy to overlook. Because of this, 75% of ovarian cancers are detected at a late stage, making treatment options limited and riskier. Outcomes are significantly better when the cancer is detected early, but that's rarely the case. And as a result, the prognosis for late-stage patients remains poor. This is why prevention is so important. Learning that most ovarian cancers start in the fallopian tubes completely redefined the standard of care for ovarian cancer. Because of this, the best form of ovarian cancer prevention is completely removing the fallopian tubes with a procedure called a salpingectomy. Most people have never heard of this procedure. Instead, they're more likely to recognize tubal ligation, where the fallopian tubes are blocked but still remain in the body. This is also commonly known as getting your tubes tied. But tubal ligation offers little to no protection against ovarian cancer. A salpingectomy reduces ovarian cancer risk by 50 to 75%, compared to only 10 to 25% with the tubal ligation. As groundbreaking as this sounds, this isn't new information in the field of OBGYN. Providers have known this for nearly a decade. In 2015, ACOG, the American College of Obstetricians and Gynecologists, published a formal recommendation that salpingectomy should be the new standard of care for permanent contraception because of its ovarian cancer risk reduction. But nearly 10 years later, this information still hasn't reached patients. And there's a myriad of reasons for this. First, there are no educational materials currently that connect ovarian cancer risk and salpingectomy in one place. In fact, there are almost no patient-facing resources at all. Most of what exists is buried in academic journals or research articles, not accessible to the average person. On top of that, this topic is surrounded by confusion and misconceptions. Many patients think sterilization procedures are reversible, the name ovarian cancer itself is misleading, and even non-OBGYN providers lack clarity on these distinctions. And finally, there are major language barriers. Everything that does exist is only in English, leaving out huge populations who desperately need this information. Seeing those barriers so clearly made one thing obvious: patients deserve better. So we set out to build a solution. We created a suite of educational tools focused on reproductive health, salpingectomy, and ovarian cancer, each one tailored to different needs and decision points in the patient journey. These include both printed and interactive digital resources designed to be scalable, translatable, and adaptable across clinical settings. These materials are specifically designed and intended for an audience of patients at risk for ovarian cancer, individuals considering permanent birth control, and English and non-English speakers, or those with low medical literacy. And overall, they're made to introduce prevention options earlier for a person, not just at the point of sterilization or pregnancy, but throughout a person's lifelong reproductive care journey. These materials were shaped through direct collaboration with patients, providers, and content experts. I conducted clinical observations, informal interviews, and feedback sessions, including participation in a workshop with the Outsmart Ovarian Cancer Initiative at Hopkins to understand what patients and stakeholders needed the most. All of the print materials and illustrations were developed using Adobe Illustrator and Photoshop with a focus on clear, approachable, and consistent visual design. For the interactive, a 3D model of a uterus was created in ZBrush and incorporated into an interactive platform built in Unity. Moving on to the results, we'll first start with the posters. So I designed a series of posters that visually compare different contraception options. What makes these posters unique is that they not only distinguish between the two often confused procedures of salpingectomy and tubal ligation, they also highlight ovarian cancer risk reduction, which is rarely included in traditional contraceptive counseling materials. Each set of posters has a different focus. The blue emphasizes pregnancy prevention, while the purple focuses on ovarian cancer risk reduction. For each option, the poster shows how effective it is at preventing pregnancy and how much it may reduce your risk for ovarian cancer. They're designed to hang in exam rooms and waiting areas, opening the door for informed conversations and shared decision-making with their providers. Next, a patient brochure that explains the differences between salpingectomy and tubal ligation side by side. It includes anatomical illustrations, frequently asked questions I observed during my time shadowing, and a fold-out layout that helps patients compare key facts quickly and clearly. It's designed for patients to take home, revisit, and take notes and share, especially helpful when navigating complex decisions outside of the clinic. Next, I created an interactive tool for patients to explore a 3D model of their reproductive anatomy. The first scene introduces clickable structures of the anatomy to set a base level of knowledge, with an accompanying description providing basic information for each clicked structure. From there, the user can explore the changes to the model following a salpingectomy or a tubal ligation, including the benefits, risks, and outcomes. It also includes a toggle that instantly switches the content between English and Spanish, making the tool more accessible to a wider patient population. This is designed to be used alongside the surgical consent process, giving patients a more engaging, visual, and self-paced way to understand their options. Next, I created a reproductive care glossary. During observations, I noticed patients really struggled to understand the language used by providers. One word that stood out in particular as a troublesome term was salpingectomy, a term patients found difficult to say and understand. This inspired me to create a tool that could help patients overcome that barrier. The glossary itself includes 40 key terms commonly used in OBGYN care. Each entry has a definition written in accessible, patient-friendly language, along with a pronunciation guide to support understanding and comfort. Terms were selected based on what came up most often during patient-provider conversations and what patients encounter throughout their reproductive healthcare journey. It also reflects languages used in the rest of the educational materials, working as a companion resource to reinforce key ideas and bridge gaps in understanding. Finally, I worked with Dr. Stone and the Decision Aid collaboration at Johns Hopkins Hospital to redefine the surgical consent forms for permanent birth control. Previously, like most institutions, Johns Hopkins used a single, non-specific consent form for all female sterilization procedures. These forms were also only available exclusively in English. In many cases, sterilization was treated as a bit of an add-on. This is a real example from clinic. A patient wanted a tubal ligation following delivery, and the procedure, as you can see here, was simply handwritten into a blank space on the form. There was no documentation of risks, benefits, or outcomes for the tubal ligation. This approach not only puts patients at risk of misunderstanding the procedure, it also opens providers up to liability. Patients can't give true informed consent without clear, accessible information. Following our collaborative efforts, 2 procedure-specific surgical consent forms, one for salpingectomy and one for tubal ligation, were created alongside providers, healthcare experts, and legal counsel. The content and language was carefully revised to accommodate low health literacy. In addition to English, the forms are being translated into Spanish. These forms mark the first known instance of a U.S. hospital implementing standardized consent forms for salpingectomy and tubal ligation, representing a significant advancement in reproductive healthcare documentation and patient autonomy. For future directions for project materials, we will continue to polish and finalize what we have already created. We will then begin to implement these materials into clinics across the country to begin widespread user testing and get feedback from patients. And then finally, our plan is to distribute these materials as an educational package to other institutions so that they too can benefit from these learning materials. I would like to thank my preceptor, Dr. Rebecca Stone, for her endless passion for this project. Corey Sandone, my advisor, for her being basically my anchor on all of this. Breakthrough Cancer Foundation, the Decision Aid Collaboration, Johns Hopkins Patient Education Services, and the Vesalius Trust for funding this project. Thank you everyone for your time. I now welcome any comments or questions on my work.
Really nice designs, really nice colors. I was wondering, so you mentioned not a lot of patients know about this. Do not a lot of providers know about it either, and which would,
So Jeff asked, since a lot of patients aren't aware of the fact that ovarian cancer mainly comes from the fallopian tubes, are providers also not aware of this as well? The answer is yes, usually. This is pretty contained to the field of OBGYN. There are cases where some providers do know that ovarian cancer primarily emerges from the fallopian tubes, especially as this is gaining a lot of movement and traction in the field of medicine. There's already been like a doubling amount of papers published on this topic in the past year alone. So I think it's on the uptick, but I feel that a lot of providers outside of any reproductive health care are not as aware of this as they should be.
Such a multi-level problem. Show so many different approaches to this. I'll talk a little bit about the collaboration. My sense of there wasn't all of these things completed. Was there a lot of back and forth?
Yeah, so a lot of this project, big part of it was simply just listening. I feel like you can learn a lot about the needs of people and patients and providers if you just listen and observe what their needs are. So this project originally did not start with all of these materials being the plan. It grew iteratively based on the feedback that I received and based on the interactions I saw between providers, patients, and just the general public. I worked very closely with Dr. Stone and Corey to kind of ideate the best ways to overcome those barriers that are in place right now for reproductive healthcare options. And the best way we went about it was to create a multifaceted avenue of materials that are able to cover the big nothing that there is for these materials, because there really isn't anything out there for any of this. So essentially our goal was, well, why not just make it all while we're here? So yeah, this project evolved quite a bit throughout the process. It was really fun. I really did enjoy my time meeting with patients and providers and learning and seeing what the dire needs were in the field. And I was really happy to help amend that with them. Thank you, David.
Is there a groundswell now for this?
Could you repeat that last part?
Is there a groundswell for this, or is that aha moment?
Yes, so Tim asked if this is basically an aha moment for the topic of ovarian cancer in general. And yes, it is. Dr. Stone is working very closely with Breakthrough Cancer, which is a conglomerate of researchers across the country studying cancer and pooling together their resources to ultimately get this information out there and to have more support systems. And in the past year alone, I've seen so much growth in the Outsmart Ovarian Cancer Initiative. We're hoping to make this an even bigger project from this. So I do believe this is a really big ground point for ovarian cancer as a topic as a whole. You can probably expect to hear a lot more about it in the next year based on how things are going right now. But it's very exciting to see the growing awareness for the disease, especially because of how lethal it is and how unknown it is. But yes, it's definitely on the up and up.
Presentation just about differences in language, knowledge of therapist procedures, and really research that you get a sense for many other procedures need a similar treatment so that patients that are non-English speaking make informed decisions.
Sure. The question was about my experience discovering other procedures that may need the same assistance and treatment that salpingectomy is getting regarding accessibility for English and Spanish. And yes, I would say a lot of procedures, especially in OBGYN, are very clearly missing accessible options. Salpingectomy was definitely the big sticking point in regards to language barriers. The fact that there was not a surgical consent form in Spanish was pretty appalling, to be honest. So that's why we worked really hard to overcome that. I imagine other reproductive healthcare procedures as well suffer from this and may come into their own spotlight at some point in the coming future. As far as outside of reproductive care, I cannot really speak on that since I was pretty confined to OBGYN, but I imagine that is a problem for other procedures that can probably be tackled in the future. All right, that's all the time I have. I'd like to welcome Juan Garcia to the podium to introduce our CA students.
The fact that I'm up here means that we're almost done. Hello, my name is Juan Garcia. I'm an associate professor in the department and the director of the Facial Eye and Body Prosthetics Clinic, as well as the associated graduate program in clinical anaplastology. It's my pleasure to introduce to you the capstone research project presentations of our two Master of Science degree candidates. For almost 2 years now, they enrolled in a novel program teaching the knowledge and tasks related to creating patient-specific prostheses as well as 3D printed medical models and other medical devices. I invite you to review the many examples of their work that's going to be at the graduate show. Both presentations you're about to see represent contributions that a uniquely trained medical artist, also known as a clinical anaplastologist, can make in medical knowledge as well as the care of patients. For our first presenter, Cherise Masuda, Cherise graduated summa cum laude from California State University, Long Beach, with a Bachelor of Science in Kinesiology Studies and a Biomedical Illustration Prep Certificate. Please help me welcome Cherise.
Hello everyone, my name is Cherise Masuda, and I'm very excited to show you all my capstone research project. I got to work with Andrew Etheridge, one of the professors in the clinical anaplastology program, in creating a touchscreen-enabled silicone finger prosthesis, incorporating single-wall carbon nanotubes and 3D digital technologies. Silicone finger prostheses are passive devices that help restore the physical appearance or cosmesis of a missing limb. These are held onto a patient's residuum by a suction sockets retention system and are fabricated with prosthetic transparent silicone and silicone pigments. A common question for anaplastologists from patients is if they can use their phone with their silicone finger. To answer, majority of cellular devices have compatible touchscreens in which they register touch by changes in the electric field strength at the point of contact. So when a human finger touches a screen, it disrupts the electric field, allowing the device to estimate the position of the touch. Since silicone prosthetics are made of non-conductive material, it is unable to disrupt the electric field, so the touchscreen function doesn't work. Currently, there are finger prosthetics in the market that have touchscreen function, such as point design heavy-duty prosthetic fingers. However, these lack the aesthetic treatment outcome for a patient. Therefore, our goal for this project was to develop a silicone finger prosthetic that 1, incorporates touchscreen functionality, and 2, provides cosmesis. So, how can we make silicone conductive? Single-wall carbon nanotubes is a multifunctional additive that can allow silicones to develop electrical conductivity at a low ratio per weight. One issue, though, is when adding black single-wall carbon nanotubes to colored transparent silicones, this will significantly change the transparency and the value of the color. Therefore, rather than embedding single-wall carbon nanotubes throughout the entire silicone fingers, we use 3D technologies to design the touchscreen prosthesis into 2 components. 1, a touchscreen conductive pad at the fingertip, and 2, a non-conductive prosthesis surrounding the perimeter of the pad. So, to start making a custom prosthetic finger, we got to work with one of our thumb amputee patients here at the Facial Eye and Body Prosthetic Clinic at Hopkins. This is showing a 3D surface scan of her residuum of a right partial thumb amputation distal to the MCP joint. Because there is no research regarding the fabrication of single-wall carbon nanotubes with silicone fingers, multiple design iterations were fabricated. The overall workflow was first the digital fabrication, then the physical fabrication to give us the final prosthesis. For the digital fabrication, I use ZBrush, Fusion 360, and Mesh Mixer, which are all 3D modeling softwares, to create 3D prints of the prosthetic prototypes and mold pieces. Then, for the physical fabrication of the non-conductive prosthesis, this involves sculpting the prototypes, lots of mold making, and casting. Then, to create the conductive touchscreen pad, we mix batches of silicone at increasing percentages of the single-wall carbon nanotubes to identify the lowest amount needed for touchscreen function. Then we created a color formula with different brands of coloration systems to mask the blast coloration to a color that resembled the patient's skin tone. Each batch was casted into the 3D printed molds for the different prototypes. For our results, we found that 0.75% of the single-wall carbon nanotubes by weight of silicone provided adequate touchscreen function, and these were the pigments that worked best to reducing the black coloration. Then, for our design, a notable discovery was the inclusion of a contact point between the patient's residuum and the conductive silicone. This allows the device to function similarly to touchscreen gloves in which the conductive material allows for the transfer of electricity from the patient. This resulted in a higher sensitivity and reliability of the touchscreen pad compared to our starting design. This iteration had no contact point and relied solely on the touchscreen pad to have sufficient conductivity to disrupt the electric field on a screen. The outcome of this pad required a higher amount of single-wall carbon nanotubes, which significantly disrupted the color. Once the two components were finalized, they were casted and extrinsically painted to match the patient. And this is the final result. We are very excited that the combination of single-wall carbon nanotubes and digital technologies allowed for the fabrication of a device that now meets both a functional and aesthetic treatment goal for this patient. Some considerations that we want to take into account is first the structural integrity over time and the longevity of the single-wall carbon nanotubes. It is important to mention that the color formula that was made for this patient can be adjusted for different skin tones. And alternatively, patients who have a low desire for aesthetics but still want silicone restorations would benefit from their entire silicone prosthesis being fully embedded with the single-wall carbon nanotubes. Lastly, since this is very new research, there's a lot of future directions for this project. That includes finalizing our IRB-approved study of reporting patient satisfaction, exploring different conductive additives, pigment systems, and improving the overall design. Lastly, our ultimate goal is to create a touchscreen silicone prosthesis for patients who have an osseointegrated retention system so that they can experience osseoperception and use their phones with their prosthetic fingers. Thank you all for listening. I'd love to give an acknowledgement to Andrew Etheridge, who is the preceptor and the principal investigator of this project. This was a great collaborative effort in creating this design, and we hope to continue with all the future directions. Next, I want to thank Ocell for donating the single-wall carbon nanotubes and the Walter Spoon Trust for a research support grant. And thank you, Juan Garcia, and the CA and MBI students for all the wonderful past 2 years here at Hopkins. Thank you, and I welcome any questions. Yeah. Yes, so it's mostly the conductive material. Oh, sorry. The question is where's the contact point? And the touchscreen pad is touching the patient's residuum. And so then it's also connecting to the end of the distal tip of the finger.
That's really cool. Oh, I was wondering how many iterations of the prosthesis do you have to create in order to find the one that works the best?
That's a great question. So there was many different tests between like doing the design and then finding a color formula. I would say for the design iteration, we had to make around, I think, 7 to 8 prosthetics, testing it over and over again to see how they would work. And then from there, we could kind of finalize the color formula and then the amount of single wall carbon nanotubes needed. So there was a lot of many tests that was done, mixing silicone and recreating the sculptural prosthetic piece over and over again. Yes.
Cherise, thank you for your presentation. I was wondering what kind of materials you guys were using to connect the touchscreen to the residual pad and that piece that's kind of in the middle.
Yes, okay. Yeah, so the question that was asked was like what type of material that we use for the different components and adhering them together. So these are made out of VST30, which is a type of RTV silicone, which is a room temperature vulcanization silicone. It's just a type of prosthetic silicone that's used within somatic prostheses. And to adhere them together, we use Silpoxy, which is a silicone adhesive, and placing them together. Oh, sorry. Sorry, for the sake of time, I have to close out all the questions. But thank you everyone for listening. And I'd like to introduce Jessica Liddicoat. She received her BS in Biomedical Sciences with a minor in American Sign Language from Colorado State University.
Thank you so much for that lovely introduction. Today, I will be talking about my prototyping of an ultrasound task trainer model of a thigh for locating perforators and autologous skin grafts. So to set some context, what is a task trainer? A great example of a task trainer is actually a CPR dummy. It teaches you the task of CPR. An anatomical model does not teach you a task, but has a 3D representation of the internal anatomy. An ultrasound task trainer is the combination of these two, maintaining anatomical accuracy as well as teaching you a task. The task that we are tackling today is ultrasound planning for autologous skin grafts. The bread and butter of skin grafts is the thigh. There are 3 main types of skin grafts from the thigh: the superficial circumflex iliac artery, the descending branch of the LCFA, and the ascending branch of the LCFA are all a part of the SCIA groin flap, alt flap, and TFL muscle flap. It's important to note that the anatomical landmarks are how they originally found the perforators when they're resecting out these skin grafts. They would palpate on the bony landmarks on the anatomy, draw out markings, and create a rough estimation as to where they should resect, and then confirm a good blood flow in the area. With preoperative planning for ultrasound, you can actually determine if there's ample blood flow coming to that area prior to resection, increasing the retention and the efficacy of the skin graft afterwards. So, what does an alt flap look like under ultrasound? As you can see here, we have 3 distinct muscle bellies, as well as a definitive fascial layer differentiating them from one another, and a very unique echoic effect, meaning that the grayscale values identify the different types of tissue. This is important to note for the model. So the problem is we don't have a trainer on the market. As of right now, residents only get training in person on patients. And one of the downsides of that is they cannot draw any parallels between the internal anatomy and those anatomical landmarks. So our solution is fabrication of an ultrasound thigh model. Now, in order to emphasize that internal anatomy, transparency is one of the main objectives, as well as anatomical accuracy, tactile feedback, so when the probe presses down onto that thigh, you want that same amount of pushback, and echogenicity, aka that grayscale value that you're going to see on that ultrasound screen, as well as cost, shelf life, and transportability and reproducibility, because we want this to be a long-term model that has a well-used live. And so to create that anatomical accuracy, I received CT data of a patient's thigh. I then segmented out the vasculature, the pelvis, the femur, and the patella. I then went into the NIH's Virtual Human Project and got the STL files for the muscle of the thigh. I then scaled those to match the segmented anatomy that I had, and then I verified the cross-section with a cross-section anatomy by Albert C. Ecclesmeyer. From there, I designed the vessels. The limitations with this was the segmentation only provided a small amount of the vasculature, and so I had to extend it to show the full scope of the anatomy required for those vessels and those flaps. So, tissue mimicking material options. What makes a tissue mimicking material? Well, scatter is a fine particulate that is embedded within the material. So when that ultrasound goes down into the material, it bounces off that particulate, causing scatter and giving feedback to the transducer, letting it know to produce a hyperechoic or hypoechoic effect. These 3 are eliminated because they have they inhibit the transparency and increase opacity of the model. These were eliminated after further experimentation for either issues with safety, increase in bubble formation in the tissue mimicking material, or overall use. glass microbeads was selected for its refractive index, matching that of the materials. Now, the soft tissue materials, we eliminated these first two because agar, and gelatin need to be refrigerated. They do not have a long shelf life, and because of that, they can grow mold, which does not allow us to have transportability or reproducibility. And for the bone, all three of these types of printing can produce a viable bone model, and that has been verified under ultrasound. However, FDM printing is the most cost-effective. For our objectives, to bounce back on this picture that I showed you earlier, it's important to note that those fascial planes are how we identify where that perforator is. The importance of having that T-section mold will be seen in the next slide. So I then proceeded with soft tissue material testing. As you can see, they had different effects on the transparency and bubble formation within the actual pieces. Bubble formation is important to note because it causes basically acoustic shadows within the ultrasound imaging. And so you want there to be a complete lack of air bubbles when you ultrasound these materials. I also did additional materials testing on the echogenicity and investigated how to create a fascial layer to create that very distinct T shape that you would see under ultrasound. I then assembled the base with an interlocking component. I wanted to maintain the anatomical accuracy, so by having all of the bones and muscle bellies lock into one another with the base, I could ensure that the model that the patients, or the model that the residents are using is true to form. I also designed both traditional and digital molds. On the left, the traditional molds, I 3D printed the positive shape of the muscle, and then using brush up silicone, I created a jacket around it and a rigid mother mold. From there, I did digitally designed molds in which I did the same process, but online through ZBrush, where I basically created a wrap around it, added in pry points, keys, injection points, and even a threaded screw for the pump. These are the results of my efforts. Not only do I have the 6 muscle group molds that you see on the top, I also 3D printed the vessel framework, the femur, patella, and pelvis in PLA, and an interlocking display base in ASA, as well as a digital design of the outer skin mold. The next steps for this project are refining the material selection. An important note is that the molds that I printed, because they were made out of ABS, they can only withstand a certain temperature. And so if the materials would like to be used to be more specific for ballistics gel or plastisol or things like that that have a higher temperature, the molds can be reprinted in a high temp resin, which is one of the benefits of going for a digital mold instead of a traditional mold. After that, once we have reprinted and refined our prototype, we would have a resident workshop, then a resident feedback survey, followed by edits, and then we intend to do a conference presentation for the Association of Microsurgical Reconstruction. And then the end goal is hopefully to produce a finalized version of this model that would increase the number of surgeons using ultrasound-based flap design, which would, in the long term, increase or improve the outcome of the flaps themselves. I'd like to give a special thanks to Juan Garcia for being my capstone advisor and helping me throughout this entire experience, Dr. Fisher for his funding and support and content expertise, as well as my other professor, Andrew Etheridge, my cohort, Cherise Masuda, as well as all of the lovely MBI students, and the large team of people who have supported me throughout this process. Thank you very much. I welcome any questions and/or comments.
You're amazing. I was wondering what you needs to.
Yeah, so we went through an IRB to get the CT data of a real patient's thigh. That was how we got the patella, pelvis, and femur, and that was segmented out. And I basically took the CT data and turned it into a 3D digital model. And then on the NIH's website, there is the Virtual Human Project where they basically segmented out an entire frozen cadaver to create a really high detailed similar to that of a CT, but different in how they created it, version of those muscle bellies. And then I scaled them to each other to maintain anatomical accuracy.
I'd like to commend you on very ambitious studies. We both know this was multi-phase, multi-stage process, which one of the research collaborators commented. This is more than what she did for her patient. So, looking at going home hard work, we're going to discuss all. I'm wondering if you could just briefly speak to how this project will be carried out.
Yeah, of course. So my intention is to pass off this project to Dr. Fisher's team, specifically Ayla Alehi. She is the biomedical engineer that I've been working with on this project. The plans for it moving forward is them to use the molds that I have created, go through the information that I have disseminated about the material selections, use said materials depending on whether or not they would go with my selection, which is the EcoFlex Near Clear with the glass microspheres, or if they wish to have something that has a higher transparency but more difficulty in fabrication, like the ballistics gel, which needs to be heated to very high temps and needs new molds to be reprinted. Then once that would be fabricated, we would plan to submit our abstract for the conference and hopefully do a podium presentation followed by a workshop if viable. An additional aspect that has been explored is to turn this into a pulsatile pump so that not only you can ultrasound it for the visual hyperechoic effect, but you could also use a Doppler ultrasound, which would tell us the blood flow, and we could have pulsing fluid throughout the model, which is one thing that we coordinated a lot with Ayla on. She actually did some lovely research on 3D printing and is currently printing for me the vessel framework in a material that is water soluble and is planning to coat the vessel framework in silicone and then melt out the water soluble material on the inside, leaving us with the complex silicone structure in like a tube form that could be used for pulsatile pump work. Does that answer your question? Well, thank you all so much for coming. We appreciate your time.
Congratulations to all the students. Very exciting to have our first year of combined presentations. I appreciate the patience and support of everyone in the audience, the family members and friends, everyone in the department who worked so hard, the staff, first year students. Everyone is welcome to attend an exceptional reception after this where you can talk to the students and congratulate them. I also want to particularly thank the faculty who were thesis advisors and the faculty outside of our department who were preceptors for our students. Thank you very much. We appreciate you sharing your projects with us, and we're happy to share our students with you. So lots of people will be walking over. Where you're headed is the Hauk lobby in the Phipps building, and just grab onto somebody who knows their way. See you over there.